Welcome back, students. We are in video 2 of 3 in modular 12, older adults needs and services. So this is video 2. We're starting off with a relatively sensitive topic, and that's the whole issue of death and dying. So you cannot be working in the field of gerontology, which is really working in the area of social services and social work with older adults, without growing your understanding and your knowledge of death and dying. It's interesting to note that this is not anything that any of us is going to avoid. It will eventually happen to all of us. For many of you, it may be that your first experience is something that you haven't had yet. For others, you may have already had a close person who's died, either a family member or a friend. And so some of this may ring true from firsthand experience, and others, this may be some new information, new ways to think about it. If this is a topic that's particularly sensitive to you, don't feel bad about moving forward. If you've had a recent passing in your family, this is just too fresh and sensitive. Please just go ahead and advance to the, out of these slides and into the next section. Otherwise, let's go ahead and talk about this. So every culture shapes attitudes towards death as well as life. So every culture has a different approach to how they deal with death and dying in their community. Most of us are not prepared for coping with either the death of others or even our own death. In terms of just America, it's my opinion and the author's opinion as well that ours is not a culture that faces death very forthrightly. There are other cultures and there are other communities, other countries that are much more forthright about the concept of family members and others dying. One of the things that the authors talk about and highlight is what's called a living will. And so a living will is a formal written legal statement that's made by a particular individual. And it's really stating what they want, what their wishes are about how they want their death to be handled. It often includes particularly information about what kind of medical procedures they're willing to take on, whether they want to be on life support systems. Um, and what this does is it gives an individual the ability to be able to um, provide guidance in terms of their own conditions as to how they want to die. Um, you often have situations where the individual client, the individual person who is the person who's dying, has a very specific idea about the way they want the procedure to be handled. So, in other words, someone may say, I don't want to be put on life support. I don't want any heroic measures. I want to pass naturally. But they may have family members who feel very, very differently. And so, if a living will is not something that's in place and provided to a physician, then the family's wishes may override what is believed to be the wishes of the individual patient. And so, in that situation, a person could find themselves on life support for weeks or months or who knows, even years, when it was never their intention or their wish to be able to be sustained in that particular way. So, that's the benefit and the importance of people having a living will. So let's talk about what constitutes what the authors call a good death. So somebody who's looking for a good death wants physical comfort, they want their pain relieved and other symptoms controlled as well as possible. They want to feel prepared to die, to have a sense of completion about their lives and of connection with those that they love. They want to be clear about the decisions they've made, to have good relationships with their healthcare professionals who help them reach those decisions and then carry them out. And they don't want to prolong the dying process or burden their families. Let me make sure that, okay. So let's talk a little bit about all of these. So the whole physical comfort piece, it's so interesting that in this country we say that we are not a supporter of euthanasia always, which is where people are provided with medications that will help expedite their death. But one of the most commonly used medications for someone who is experiencing physical discomfort and needs to have their pain relieved, particularly at end of life situations, is morphine. And quite frankly, morphine contributes to people's blood pressure lowering, their heart rate lowering. Um, it's a way of really kind of moving people towards eventually dying. And so when you talk about relieving their physical comfort, a lot of those medications, morphine included, is actually not only relieving their comfort, but it may be hastening their death. They want to feel prepared to die, have a sense of completion, connection with those that they love. Um, there's evidence that says that people who have still unresolved issues with family members and those kinds of things may, try their best to hold on, to stay connected, to maybe try to resolve those particular issues. There's been interesting stories that have talked about that, the patient may be close to death, they may be in the hospital, they're really sort of ready to die. Family members all gathered around and, oh, dad, please don't leave us. You can't leave us. Please hold on. All these different kinds of things. And then the family members say, well, okay, we're going to go get some coffee and we'll be right back. And during that 5 minutes that they're gone, that's when that person passes. So they finally are in a place where they feel like there's no pressure to try to keep themselves alive, and they sort of give themselves the right to die. And so that's been something that you know has been talked about for years in terms of medical providers. And one of the things that's also interesting is that when people have terminal illnesses, whether it's cancer or any other kind of terminal illness where there's a variety of different treatment options, it's not unusual for a person who's maybe suffering tremendously. Maybe they've gone through 2 or 3 or 4 different kinds of treatment programs. None of them seems to have really made a significant difference, but their healthcare provider, their physician, is coming back in and saying, hey, you know what, we've got this brand new thing and we could do this, and it's going to cause you a lot of pain, and it's very invasive, and we got to go in and do surgery or something like that. It's not outside of the realm of possibilities for a patient to say, you know what, I think I'm good. I've had enough. We've tried all these different treatments. Nothing's really worked. I'm not really invested in trying something else that's going to bring me more discomfort. Just give me something that makes me comfortable, and let's kind of let this process take its role. So it's important to recognize what the motivations are of a healthcare provider in terms of the fact that for many physicians, some physicians, there's a sense of, oh, I didn't do everything I could have done. But remember, we ultimately want to leave the decision up to the patient. And they don't want to prolong the dying process or burden their families. So, sort of on the opposite side of this, what constitutes a bad death? Usually marked by pain and fear. When a person feels anxious and alone, attended by bustling strangers with little time to explain or reassure. When a person is subject to hospital stays and medical procedures that are probably futile and cause trauma and discomfort because nobody has clarified their purpose or determined whether he or she really wants them. And if there's no one to guide the person and their family through the experience and to encourage the conversations that might allow a more peaceful passage, that's an unnecessarily bad death. So just like we were talking before, I kind of jumped the gun on this, but this whole idea of more treatment, more hospital stays, more procedures that may or may not result in, a longer life expectancy. Those are the kinds of things that really constitute a bad death. Um, this whole idea of attended by bustling strangers with little time to explain or reassure, a lot of people feel like they want to be at home when they die. So the idea of being on a gurney in a hospital, hallway because, maybe they're waiting to get a bed in the hospital and those kinds of things. That's kind of really contributing to what might be categorized as a bad death as well. So all of these things are sort of the opposite of what we'd like to see happen. And certainly social workers, medical social workers in particular, can play a fairly significant role in terms of helping to guide a person and their family towards more of the characteristics of a good death as opposed to a bad death. So one of the contributing factors or services that can really help to have a patient result in having a good death and help avoid the elements of a bad death is hospice care. So hospice is a care program for terminally ill patients. It's in a familiar environment that minimizes pain, maintains personal dignity and control over the dying process, enables patients to die with dignity and support, often away from a hospital, allows individuals to have control over their own death. So hospice programs are quite varied. So a person can be in their own home and have hospice services brought in. People could be in a nursing home or a convalescent hospital, and they could be. It could be determined that they are terminal, and hospice programs or hospice services could be brought into that kind of a facility. Or a person could be in a hospital, and hospice services could be provided there as well. Um, One of the saddest things about hospice is most studies indicate that hospice is brought in very, very late in the process. Um, More than often, it's maybe brought in the last week before a person dies. When in reality, hospice services can be implemented at any point 6 months before a person is expected to die, to be honest with you. So if a physician says, I hate to tell you, Mr. Smith, but um, your um, your condition is terminal. I would assume, based on my prior experience with this disease, that you have approximately 6 months left to live. Quite frankly, hospice could be brought in at that particular time. So, and hospice includes everything from medical care and minimizing pain to counseling, helping the families care for the person if they're at home and those kinds of things. Um, so hospice can be a really, really valuable program for families as well as the individual through the dying process. So the authors report that patients say they want control over decisions about their care, but only a minority have prepared an advance directive, which are legal documents that specify the kind of medical treatment and interventions patients want or don't want. So that goes back to the concept of the living will. So while the vast majority of people tell researchers they'd like to die in familiar surroundings, say at home, about half of all people still die in their hospitals, and another quarter that are dying within nursing homes. So even though we've got these tools and these resources, such as a living will, they seem to be underutilized by and large. So let's talk about aging and mental health. So the mental health of older adults um, does not appreciably differ from that of the population in general. So, in other words, just because someone's getting older does not necessarily mean that it's inevitable that they are going to experience mental health issues. If they've had good mental health in their 20s, 30s, and 40s, there's no reason to suspect that they're going to have poor mental health as they get older. Now, there are some conditions, and we're going to talk about those, such as Alzheimer's disease and Parkinson's, that obviously contribute to issues around mental health. Simply becoming a person who's learning to live with a chronic disease or who has a terminal illness, all of those may, contribute to less than optimum mental health. But overall, in general, the mental health of older adults is not consistently poorer than that of the general population. Um, Dramatic changes in the mental health of individuals are seldom caused by the aging process alone, again, except in the situations of Alzheimer's or Parkinson's. And the way that an individual interacts within the environment strongly influences the individual's mental health and perspectives about growing old. So this is all about aging and the ecological or systems perspective. So again, the environment that an individual interacts within can have a significant role in terms of their mental health as they grow older. So most people would say, I want to be in my house. I want to be in a place where I feel comfortable, where I know where everything's at. But unfortunately, if they find themselves unable to be able to remain safely in their house anymore, they may find themselves relocated to a retirement community or a senior complex or a convalescent hospital. And all of those are going to obviously require an adjustment to their environment. And there could be mental health consequences to people either successfully or unsuccessfully making that adjustment. So issues around social isolation, loneliness can result in maladaptive behavior or poor mental health. Some people, if in terms of older adults, may experience over medication that can cause memory loss, disorientation. This is referred to as polypharmacy. So, and there's interesting information out there. If we had more time, I wish we could talk about it, but about how seniors often manage or not manage their medications. And one medication is that they're taking is counteractive to this medication. The reason that they're experiencing these symptoms doesn't have anything to do with what's happening with them physically, but it's a side effect of the drugs. And I think the way that that comes about is because we've got such a disjointed healthcare system, meaning that does your cardiologist know what your internist has prescribed, and does your heart doctor know what your, I don't know, primary care doctor has prescribed, and those kinds of things. So if there's not sort of this centralized place where somebody's looking at all of your medications and seeing whether there's any that are counterproductive to the other, then certainly polypharmacy is something that people could be at risk for. And then finally, depression may be caused by bereavement, anxiety related to income, maybe having this very limited social network, relocation, or obviously health concerns. So as we talked about, there can be insecurity about income. The greatest source of retirement income for the majority of older Americans is Social Security. We've talked about that. That's that program that you pay into over all the years that you've been working that you are then able to draw from when you decide to retire. Older adults may worry about having enough money to live on, not being able to work to supplement Social Security income. There may be a level of uncertainty about the future of Social Security benefits. We talked about that earlier, having enough money to meet support and social service needs. Pre-retirement planning, the process of planning for retirement in advance of the actual retirement date. Couldn't promote this enough. As a person who's approaching a retirement portion of their lives, I am so happy that years and years and years and years and years ago, I started, putting away a little bit of money every single month, and it's amazing how much that money can grow, and you just don't touch it, and you let it get bigger and bigger and bigger, and it's going to be really, really helpful and really great when I finally reach the age of retirement. So, again, couldn't Couldn't recommend it enough. Even like $20 a month in your 20s. I know it sounds crazy, but you'll be amazed how much it grows over time. There can be issues around health and healthcare services. Obviously, chronic disease may be more common in older adults. So, diabetes, heart disease, asthma, pulmonary disease, breathing disease. People may refuse to seek treatment until health conditions become severe or life-threatening. Sometimes prescriptions, they may feel that they're too expensive and they can't afford them, therefore they go without. So what we have are two government programs, Medicaid and Medicare. So if you are a senior who has a relatively stable income, then you would probably be using primarily Medicare. But if you're a low income senior, you might be using a combination of Medicare and Medi-Cal. And you'll often hear that referred to as Medi-Medi in California. So again, if your income is low and you're a senior, you might be eligible for both programs, but basically most folks that are 65 or older are using Medicare. And what is the burden of chronic disease for older adults? What we know is that it affects life expectancy. Many of the diseases that claimed our ancestors are no longer the threats that they once were. What we see are things like cancer, heart disease, always sort of being in the top in terms of diseases that are most likely to be impacting life expectancy in the United States. So here we go. Heart disease, leading cause of death every year, except from 1918 to 1920, when the influenza epidemic took its toll. Since 1938, cancer has held the second position every year. Greatest risk as people age. But you have other chronic conditions such as stroke, chronic lower respiratory disease, Alzheimer's disease, and diabetes. Also, continuing to take a look at things like influenza and pneumonia. That's why they talk about the fact that people can die from the flu. You can get the flu, turns into pneumonia, and that's what you die from. And we certainly do know now that COVID-19 is something that significantly can impact more older adults, and particularly older adults of color, in terms of respiratory conditions as well. So we are going to pause here. This is video 2 of 3 of Modular 12, Older Adults, Needs and Services. And when we come back, we are going to spend some time talking about Alzheimer's disease.